Great. So welcome everyone to, I think, probably the start of the afternoon breakout sessions for everyone. This is, I think, a really interesting session because this is on transparency. Transparency can kind of be one of these sort of suitcase words. You can pack a lot into it, and like words like accountability, management, those sorts of things. You could put in governance, you could put in reporting, you could put in conflict of interest. We're going to use a little bit tighter definition of transparency. We're going to talk about the release of information and the release of information in a way that drives the type of change that we want to see in our health system. I'll be very, very blunt on this. I think the scholarly debate continues a little bit on transparency. The practical debate, for all intents and purposes, is closed, though. And we know through a series of natural and controlled experiments that when people get information that they can use and that they feel they need to pay attention to, they thankfully start to do things a little bit differently. There's a lot of economists and deep thinkers who sort of laid out thoughts and theories about why this is the case. Ideas about reputational damage. You've probably heard from the behavioral economists about ways that you can nudge people in certain directions. I'd always like to take a very simple approach on this, though, and that's kind of the busy, good person theory. If there's a whole bunch of people working really hard to provide care, to run organizations, to engage in different activities, just putting another piece of paper in front of them doesn't mean they're going to do anything with it. But when they get a chance to actually pay attention to that piece of paper, or they know it's going to be in the paper, or it's going to be on the media, or they can see how they're doing against their colleagues, you can actually see positive change happen just by the fact that now people who are bright, engaged, want to actually pay attention to the data and do something about it. To deal with this today, though, we're going to hear from 4 people. I could spend the next sort of 45, 50 minutes detailing accomplishments and activities. I'm not going to do that. What I am going to do, though, is lay out very quickly an arc of where I think the narratives today will go, introduce our speakers. I will introduce them one by one right before they speak so that you're not having to kind of create a play sheet or a little list of the dramatic personnel. And then I'll moderate some questions afterwards. The final thing I'll sort of close on here, though, is that we can think about transparency and trust as 2 very tightly related concepts. There's really sort of 2 ways to think about this trust. The first is the trust that a system is doing what it's supposed to be doing, that the people in the system have the skills, the capabilities, the competencies, and are performing to what we'd expect. Transparency has a key role in that. The other is an aspirational notion of trust, that people are constantly improving. And in some ways, this is the difference between looking at a report in 1 year and looking at a series of reports or pieces of information year over year over year. When we think about kind of a sustainable approach to transparency, I think it's great to start with, obviously, are people doing what they're supposed to be doing? But it's really important to move to whether or not things are getting better and better. And that's a way that transparency justifies the trust, and in many ways the delegated authority that we put in all aspects of our health system. So what are we going to talk about today? Well, we're going to hear first about kind of, I think, the best practices and lessons learned from around the world. Get a sense of kind of what's going on in transparency, because although Ontario has led for a long time in a number of areas of measurement, it is a very big world, and perhaps the lessons of transparency are more transportable than anything else. They're often independent of capital and expenditure levels. They're independent of questions about how we organize our system. They're independent of questions of professional sort of relations and organizations of care, because the lessons of transparency really allow you to understand how systems function next to each other. Then we're going to hear about 2 examples that are very, very important to Ontario. First, about what's happening really at kind of a pan-Canadian level, and then what's happening within cancer in Ontario. Cancer's been one of the places that led really more than a decade ago with very, very detailed reporting, and since has sort of built on that for a long time. And finally, we'll finish off with an emerging area of transparency that's important. That's the notion of conflict of interest. And it gets back perhaps to those first stages of transparency. Are people engaging and doing what we'd expect them to do, and is their focus where we'd expect it to be? All right, with that, let me open up and do the first introduction. So Daphne Carr is the executive lead at Health Quality Ontario. Executive lead is one of these very, very dangerous titles because what it allows people to do is to stuff a whole bunch of things into your portfolio and kind of expect you to do it. But she and I have been working together for a while now on issues around performance measurement, performance reporting, and really, I think, fundamentally important questions about how we can do it better in Ontario and how we can actually do something that will provide some leadership around the globe. Daphne?
Thank you. Thank you very much, Stacey, for that introduction. So I've got my 10-minute card. Let's see. Hopefully I don't waste it on my clicker. Actually, now I want to go backwards. Yeah, so in the 10 minutes that I have, what I'm going to cover is, first of all, a sentence or two about HQO's accountability, why public reporting is important, quickly how Ontario is doing, what leading organizations are doing, and what the public and the stakeholders are thinking and telling us here at HQO, and a little bit of where public reporting is heading, or at least show you a couple of interesting innovations. So the first statement I'll say is that thanks to Stacey, as we heard in the plenary session this morning, introducing legislation around ECFA, HQO does have a legislated accountability to publicly report to Ontarians on health system performance. So on an annual basis, as we know today, the Measuring Up report is published, and that is a legislated accountability, so it's not really a choice. So why public reporting, and how does it link to transparency? In 2012, we were very lucky to have the Agency for Healthcare Research and Quality in the United States put together a technology assessment, I should say. It's an evidence-based report. It weighed in at over 600 pages, and it covered these questions. And thanks to my colleague Irv Fandala, we have a really, really quick summary of these 600 pages here. Most importantly not most importantly, but what I want to focus on is the evidence around, does public reporting improve care, around question number 1, and does public reporting lead to changes in healthcare delivery? So for both those items, there is still debate, but the evidence is much more solid than some of those other items here. And to most of us in the room, our job is really around question number 3, which is changes that can lead to, or evidence that can lead to changes in healthcare delivery. And that's what public reporting has been proven to be able to do. So quickly telling you what's going on in Ontario, I'm not going to do justice to the review that we did at HQO, but because we have this accountability to publicly report, we felt it's important to go out there and understand a little bit more what's going on in Ontario. We reviewed 23 websites. 3 of them were national and 20 provincial. One of them is here, of course. 2 of them are here. And just to sum it up, there are 3 ways that health system performance is reported online, and we don't often think of it this way. Indicator graphs, which are visual diagrams, PDF reports, which are really these fixed layout documents, and credential protected information that require passwords. And when we started to look at it that way and categorize the websites in Ontario, what we saw is that 6 out of 23 are dynamic, meaning you can actually search and find the information you're looking for easily. Most of us publish our information, and many of you in this room might be one of those organizations, and nothing wrong with it, but you're publishing information in a print PDF format. These are much more difficult to search. In Ontario, there's over 350 indicators being reported. A huge number of those are coming from the Cancer Quality Index, and a huge from wait times as well. There is overlapping between sites, and you might not be surprised to know that most of us focus on the provider and the public. So even though we've been talking a lot about public and patient engagement, I can tell you that there's very little out there in Ontario that's focused to that group. So as you know, when we talk about, when we look at Ontario and try to understand what's going on in Ontario, the next thing we want to do is look externally. And I don't know about all of you, but I'm often asked, what about the NHS? It seems to be the first place we go. But really, we looked at the NHS and other leading models. Again, I'm summarizing a lot of information in these key points, but what we did see with the international organizations, and actually some of these are national, some of them are Canadian, 4 out of the 9 sites we looked at, the primary audience is the public, so a little bit different than Ontario. Really interestingly, 4 out of the 9 are using visual symbols and infographics. They are not using graphs to convey their information. Most of the sites had over 100 indicators, but interestingly, 2 of the 9 sites had less than 15, and that's how they were reporting on the health system of whether it's a region or a nation. 2 sites included public comments and reviews, and 2 sites included ratings. So again, although we hear a lot about ratings and comments, it's not that commonly used. So I think, surprisingly, there is not one approach that trumps when it comes to public reporting and transparency. It's done in many, many ways. As we decided to find out a little bit more, and again, we just wanted, at HQO, wanted to do a couple of consultations ourselves. There is a lot of evidence and literature about this. In fact, just yesterday in the UK, there was a really interesting report released about public reporting there. When we met with our patient groups, this is what they told us. I don't think any of you will be surprised. Searching online is driven by a personal event, primarily. You're looking for information to help with your micro need. You're not really looking at what's going on at the broader health system. Internet search engines are where everybody starts. Almost every conversation started with, I Google it. Websites can be helpful, so we might think we have a great website, but they are often confusing. People the public really likes online ratings and reviews. They're commonly used, even though they know their pros and cons. High value on anything that can help with navigating your treatment and your care, not so much about the overall health system. Again, I don't think any of you would be surprised. Many of you in this room are people that we spoke to and met because we are all in the business of improving quality, and we do it through public reporting and other mechanisms. Very high summary of what you said to us when we met with you around what should we think about transparency at HQO. We were told what it should be about. I think this will resonate with many of you around accountability, highlighting inequities, variances, celebrating successes, which we often forget, instigating change and quality improvement. Many of you told us what it shouldn't be. And again, I think we have to listen carefully. And this is, I think, what Steny was saying. Transparency for the sake of transparency does not often actually lead to transparency. We might think it does. Shaming is not something we're interested in, and in terms of motivating. Everything and anything that is published would be overwhelming, but we do have to be careful about that. There is a lot of information being published. Even though I gave you a bit of a sense of the indicators that exist in Ontario, there's a lot more information when you just look at reports. And then being unfocused without an objective is a big worry, and this is a big one for HQO because we are focused on improvement and quality improvement. And so if you are putting information online and it's not focused potentially without a specific quality objective, are you going to achieve what you're trying to achieve? So, heading into the 3-minute mark here, I have to set a good example for my other speakers here. We feel at HQ that we are at a bit of a decision point of significance, and this has been influenced by the work that we've been doing with Steny, the working group on transparency, chaired by Steny. What we feel is that it really boils down to information that is publicly reported is primarily of that first kind, information for improvement. So most of us in this room, I'll call us quality improvement professionals. We create the measures. We work with our peers and our colleagues. And really, we're looking to have broad indicators that help fix and improve the system. But what we heard from patients and what the literature says is that's actually not what the public is looking for, and it's not what when you think about public reporting or transparency, what they're really looking for is information on navigation, on choice, and decision making. And we're just not giving them that information. There are sites, obviously, that do a good job. We're going to hear about some of that. But even then, I would argue that we're at the very beginning of the journey of truly identifying what the public is looking for. In the consultations that we had, many of the members of the public talked about the smell of a nursing home or the cleanliness of a nursing home. And so we've got to really think about measures that are maybe very difficult to get information and data on. And that's, again, an area that, as quality information professionals, quality improvement professionals, we're not that comfortable if we don't have the information, the data. We like to start where we can start. But here's the problem, is that while we're debating all of this information, there's a backdrop of innovation. Many of you have probably used RateMDs, maybe Yelp. And that void is being filled by those organizations, and they are providing information through ratings and reviews that are helping the public make choices and navigate. And just to give you a sense of what others are doing in that sphere a little bit. So this is from the United States. I think some of you have heard about ProPublica, an independent not-profit newsroom that produces investigative journalism. They say in the public interest. For those of you out there that you might believe it's actually not in the public interest because of the quality of the work, but what they've done is they've partnered with Yelp to combine data on performance with Yelp reviews and ratings. So a very interesting phenomena. The Centers for Medicare and Medicaid in the United States, what they've done for many years is provide publicly available information on a whole group home, dialysis, hospital, and physician care. And they're now bringing that together into a single website for a single point of access and entry. And lastly, in my 1 minute mark, we once again look at the NHS, and very interestingly, they are merging what is a non-urgent telephone number and creating a digital platform and combining it with their very strong branded NHS Choices website. And the idea behind this is that there's one platform for all digital transactions in the NHS. But what's most intriguing from my perspective is that what they're trying to really do here is provide a clinical pathway that simplifies the patient journey and improves the patient experience. So this is really a game changer in my mind. It's very bold, and we'll be watching this endeavor very closely at HQO. Because providing this kind of information online to the citizen, in my opinion, would be truly groundbreaking and very transparent.
Thanks, Daphne. Up next is Kathleen Morse, who is the Vice President of Research and Analysis at the Canadian Institute for Health Information. And I think perhaps more importantly is both sort of had hands-on and sort of steerage now of an awful lot of reports. And so seeing, I think, probably the whole gamut of activity that leads up to a report. Is that a fair way to put it?
I think
Great.
that's fair.
Kathleen.
Thank you, Steny. And thank you, everyone. I think people are very familiar with CIHI, but just the 2-second overview is that we develop standards. We work with you to collect comparable information. We try and do some sense making once that comes in, and try and present it in a compelling and a timely way to the field so that it can be used. So a big push in recent years to try and get more transparency. I'll talk a little bit today about CIHI's journey on that front in recent years, but note that it builds on a pretty long tradition of transparency. From the time we were founded 20 years ago, we were reporting at a provincial level, then at a region level, and it's only about a dozen years ago that CIHI sort of actively approached each of the provinces and sought agreement to actually have hospital-level public reporting. So that seems just like the norm now and what we're all used to, and that's still a pretty recent phenomenon. But enough with history, and we'll kind of fast forward to 2012. And that was a time where we saw, I think, a tremendous amount of enthusiasm for transparency and a lot of interest in, and growth in public reporting. And I think that some of, the positive side of that was this great energy. And the downside was an overwhelming amount of information that some in the field were saying was verging on indicator chaos. So it's where we sought off on that. We thought it would be a good role for CIHI to try and play a leadership role in some respects in terms of providing some tools to think about reducing indicator chaos. One of the first things that we did was to try and say, well, what is it that we're trying to understand in the first place, and developed a conceptual framework, which you won't be able to read here, but you can see there's many parts to any health system. They all connect in some way to each other. And the diagram was really trying to put some mental energy into understanding what it is that we were trying to measure. The second thing that we did was to create a integrated website to try and understand health system performance in a different way based on a couple of fundamental principles. One of them is that the information be well integrated, one piece to the other. And the second is that transparency means very different things to different audiences, and we really needed to focus on who we were trying to provide information to. So the very top of the pyramid is the public. And there we undertook a very extensive public engagement exercise with about 3,000 Canadians. And it was really all centered around what's important for you. What is it that you want to know? And we got some interesting answers. The first one was probably not too surprising for many people here. It's, will the health service that I need be there when I need it? So it was really about access. People were interested in how much services cost. They were interested in how the system helped them stay healthy. And they weren't particularly interested in quality and safety because they presumed that that was there. So it was an interesting piece trying to work through that. And we developed a top layer of the website trying to use search terms that people might be interested, so they could look up their city or their hospital or their postal code. And try to present the results in plain English, which was a challenge. I think just inside our organization, it was hard to let go of the precision in the technical language to actually find a way to communicate. The middle layer is focused at probably a provincial policymaker level, and it has more indicators. So the first has only a few. The second layer has about 37 indicators, and more recently some 9 new indicators for long-term care. And it looks at both process and outcomes. It's available to an engaged public, so it's there for people to look at if they're interested in. And it includes visualizations that actually kind of help people get a sense at a glance of comparative performance. So there's many different items there. One of them that you may have seen is a 3x3 matrix, where the top right corner is where you hope many of your indicators would fall, where you're doing better than average and improving. And the bottom left with the 1 in it is an area where you're actually below average and your performance is declining. So this is just an example of many of the kind of snapshot tools that are available there. Finally, there's a base layer to this that really targets analysts in health regions and in facilities. And it's a layer that supports slicing and dicing and drilling down right to the chart level to really understand what's underneath some of the data. So this information is probably less about the outcomes and the process measures, and it's more about information to support performance improvement. The bottom layer is available to authorized users only, but it still has a transparency piece. It runs on what we fondly call the nude beach principle, where everybody can see each other's stuff. We also have, in addition to these 3 layers, another type of transparency we provide is through our analytical reporting function, where we put out in the neighborhood of 12 reports a year. And just to give you a flavor, some of the ones that are coming out in the next few weeks are, we have information on health system expenditures, we have information on sort of how Canada fares on OECD comparisons and what would happen if a province looked like a country within Canada, how they would compare. And we have information on health inequalities. So really quite a wide range. One of the things that we think has helped the system become comfortable with some of this transparency is the fact that there's clarity all the way through. So from the time the standards for data collection are set, we're very clear on the data quality results, the methodology that we use. There's information that people can take a look at there. And I think that's an important piece to consider. The last question is, has any of this made a difference? So you can look at that. So the answer is we're not sure. We've tried to find out. And we've looked at it from both sort of a big picture and a more micro level. So if we look at the big picture, we actually sent out a survey to a large number of people, and we asked them if they'd used any CIHI reports or tools. And if they said yes, we asked them on a scale of 0 to 10, how useful was this to their work? So I'd say we got about a B plus, somewhere between a 75 and an 80 in terms of this. So I think that was encouraging. It was more encouraging to us that 40% of the people who responded could actually point to a measured improvement that they made that had been sparked in some way by the data. And we did a little bit of work in follow-up focus groups with those folks, trying to understand was that really true. And it seemed to be. So I think we're encouraged that we have room to improve, but we're probably making some headway. The other way that we can look at it is an example of what different users do with the data. And it's hard to draw big trends from this, but one I can just sort of pull up as a for instance is some work that Sunnybrook Health Sciences did. And I'll pull on this example because it's one that we've presented with them in the past before, so we know they're comfortable with it. These are the small stories of good improvements where there's been focus on a particular indicator. So here, during the data preview or nude beach phase before public release, Sunnybrook took a look at all of their data, and like many facilities, they occasionally find something that's different from their expectations, from their peer performance, from the provincial average. And sometimes it's surprising because within a facility, you're often tracking your own performance over time, and you need the bigger picture context to see those surprises. As a result of this, and then this particular hospital found sepsis as something that they were interested in understanding better. So they did their own chart pull. They took a look at things. They found that urinary tract infections was a piece that they wanted to look at more. And they did the sorts of things that people often do when they're trying to get better. They put a lot of energy into trying to address the issue. UTIs are on the QIP. They set measurable goals for improvement. They have lots of action plans in place, and I think they're looking forward to seeing how this indicator fares over time, and particularly in relation to their peers. So still very early days, both for this particular example and really for some of the new ways that we have of trying to present data in a useful and transparent way. But I think we're seeing some progress, and we're encouraged by that. Thank you.
Our next speaker is Virginia McLaughlin. Virginia's had a successful career in business. She's been a hospital governor, a whole list of other things, but our own collaboration is through the Cancer Quality Council of Ontario, where she's been the chair for a number of years. Virginia.
Thanks, Danny. So it's really a pleasure for me to be here and to be speaking to you all this afternoon. And it's really wonderful to see how many people are so deeply committed to improving the quality of care in Ontario. I think we see that by the number of people at the conference, and it's great to see so many people here who are interested, obviously, in public reporting. So presenter disclosure. I didn't see a disclosure slide for everyone earlier, so again, in the interest of openness and transparency, there you can see it. On behalf of all of us, there we are. And I don't think that there is any conflict of anybody on this panel. So first of all, a little bit by way of background for the, first of all, the Cancer Quality Council of Ontario, and then I'm going to get into the index in particular and our relationship with Cancer Care Ontario. You can see there on this slide that we were established in 2002. We are an arm's length advisory group to Cancer Care Ontario, and we are set up to provide advice to CCO and the Ministry of Health and Long-Term Care in their efforts to improve the quality of cancer care in the province. We are composed of cancer survivors and family members and have been since the get-go, which was in 2002, as you see. And I think certainly one of the first organizations that intentionally involved cancer survivors and family members on the council. In addition, there are experts in the areas of oncology, health system policy, performance measurement, health services research, and healthcare governance. So really a multidisciplinary group on the council. And we also attempt to to be geographically diverse across the province. So rather than being sort of Toronto-Hamilton centric, which is always tempting when you're functioning out of Toronto, we have representation from across the province. We are working on diversity as much as we possibly can. And our mandates are twofold: to monitor and report publicly on the performance of the Ontario Cancer System through the CSQI, which is the index. We'll get to that in a moment. And to monitor quality improvement through national and international benchmarking. And the Secretariat is housed at Cancer Care Ontario, and so we're able to benefit from economies of scale and the resources at Cancer Care Ontario. So the graphic there shows the relationship, and just again, in terms of the index itself, if I can just direct your attention to the lower left, which is the Provincial Leadership Council and the Clinical Council. So we are able to benefit from the expertise around the Cancer Care Ontario tables, many tables, as we develop a variety of our projects, including, importantly, the CSQI or the index. There, just in a quick graphic, the members of the council, and you can see there the diversity of skill sets as well as geography. So the council has four, call them work streams, and the index is there on the left-hand side. We also have Quality and Innovation Awards, which will be announced on in November at the signature event, and that's really an opportunity to reward and to feature and draw attention to astonishing work that is being done across the province. We also have an annual programmatic review, and that is a review of the program, one of the programs of Cancer Care Ontario, and in addition to the signature event, which we hold in November, the work of all of these things do feed and inform each other in what I would call a real virtuous circle. So none of these initiatives of the council stand alone, and specifically as it relates to the index, many of the things that will come up in either in our programmatic review or the signature event as gaps or things that we could be doing better will find their way back into the index. So just a little bit by way of background of the index. It started in 2005, and Steny knows this better than I because he was there right from the beginning. It started off as a strategy map and the performance indicator identification and selection. You can see there how starting from a lit review and then a reduction to a more manageable number of indicators through a variety of different processes, working groups, and so on. And the strategy map, you can't see the words there, apologize, but it does cover a variety of different aspects of quality as we would think of them today. The index evolved from that framework to the current CSQI framework that we have today. You can go on the website, and I will at the end of the presentation put up the website so that you can hopefully go and look at it and play with it and work your way through the index. It's very large, it's very comprehensive, it is searchable, it's interactive, and reports at a number of different levels. But this, in a nutshell, is the index quality framework for 2015. The index is not a balanced scorecard. It is a quality improvement tool. Indicators, as you can see, come on and go off, and some of them rotate. And they do all of these things for a variety of different reasons. I won't get into all of those now because we'd be here all day, but just so that you can really see that this is a dynamic index. In terms of just a quick overview of how indicators end up on the list. For example, they must credibly measure quality at the level of the cancer system. It's important or relevant to stakeholders. We really want these things to be meaningful. We want them to help to make a difference. It needs to be linked to the mission of CCO, which is to be the best cancer system in the world. It has a clear owner within CCO that will maintain accountability. I think we heard about this earlier today, how important it is for change management that there be an owner. So So every one of these indexes has an owner, somebody who is in fact responsible for it at Cancer Care Ontario. It has clear directionality. We want to know that it can go up or go down. It has a credible evidence base, and it meets data quality standards. We also need to know, again, in terms of choosing one over the other, that it strategically increases the breadth of measurement across the SQI quality framework, that it can be used to describe outcomes from a patient perspective and or as a big dot indicator. We want to see that it helps shape the message of each quality dimension and aligns with their definitions. And so you will see sometimes that there are many or few indicators in any particular column or line. And where we see gaps, we really try to find an indicator to fill those gaps. I see my time is running out, so I better move on. So this, again, the 2015 CSQI, an overview. I really like this slide because it shows a number of different things that the index itself showcases. The index itself is 1,000 pages. Don't be intimidated by that. It's very easy to use, but just in a nutshell, you can see across the top are a variety of different tabs you can go and look at. You can see down not the left-hand column, but the second left-hand column, the domains, so safe, effective, accessible, and so on. This year, our special focus story was lymphoma. We always have a special focus story. It really brings the index to life, and so you can go and look at the special focus story, and it absolutely contains patient comments and patient stories, and then you can see some of the other things, Ontario surveillance data, international comparisons, and so on. And we're always asked at our public launch about those international comparisons. So there they are. In terms of transparency and the performance improvement cycle, I'm just going to show this because I really want to get to a couple of examples, and I've only got 3 minutes left. But you can see that there is a performance improvement cycle there. So, sorry. There we go. Success stories. So how has the index actually helped to improve the performance of the system or the quality of the system? So I'm sure everybody in this room remembers IMRT. It was a new technology in 2009, or considered to be a state-of-the-art or standard of care technology in 2009, but it was not widely used. We put it on as an indicator, and you can see how the adoption of IMRT has moved forward very, very rapidly across the system, so that in 2012, only 3 years in, it was introduced effectively across the province. And this year, 2015, the indicator was dropped. And the reason it was dropped is because it had met the standard, it had exceeded the standard consistently, it is now routinely used, and so we feel it is no longer necessary for us to measure it and to report. I should just add that many of the measures that we know we drop continue to be measured and monitored and reported by Cancer Care Ontario. A second quality improvement example is around radical prostatectomy. So there you can see there was an internal audit. It showed that the positive surgical margins were at a too high a level. CCO put in a program to attempt to reduce those levels, and you can see again that over time that has been achieved. And again, similarly around the margin in prostate cancer surgery. So finally, for more information, you can, and I hope you will go to the website, www.csqi.on.ca, and really learn more about what we do and how we do it. And given the examples that I've given, how we have attempted to improve through measurement the quality of the cancer system and the performance of the cancer system in Ontario. And they're just a little example of the cancer journey, and again, how we measure and how we look at things across the patient journey. So I'll just leave it there, because I could talk more about that, especially around survivorship, but we won't go there right now. So there we are, and it's been a pleasure. Thank you.
Okay, now we're going to turn to Trudeau Lemons. Trudeau's a colleague of mine from the University of Toronto, and among many other things, he's also the Skoll Chair, which I think is probably our most prestigious chair in Canada in health law and ethics. Trudeau?
So my presentation is a little bit different. So I will be speaking about the promotion of transparency of industry, healthcare provider, patient advocacy, academic relations, actually the basic relations between industry and everyone involved in the healthcare sector. So I'll first say a little bit about why transparency. I'll have to be reasonably short about that, but I'll try to give you a basic idea of why transparency is being promoted in this particular area. I'll say more about what others are doing, what Ontario is already doing, and I'll finish with some brief discussion about what are the basic issues. If we want to implement transparency measures, what do we have to think about? What are the kind of basic challenges that we can be dealing with? If you look at the justifications given for transparency measures, so-called Sunshine Acts, for example, in the United States, there are generally three basic justifications that are given, namely that it can lead to the potential limit in healthcare spending, that it certainly should promote also health and safety of patients and consumers, and that it should ensure the integrity of and the trust in the integrity of the healthcare practice, and the decision-making processes, even the regulatory processes, funding decision processes, and so on. So this is related actually to a historical record and evidence obtained through studies and through prosecutions and so on that that there is a impact of financial relations between industry and healthcare providers. And with industry, I mean particularly the pharmaceutical industry, but also the medical device industry, the health technology industry in general. When I give examples, I will primarily focus on the pharmaceutical industry, but we should not forget that there are certainly other important players in this game as well. The idea behind limit in healthcare spending is obviously that expenditures of pharmaceuticals and health technology in general are among the fastest growing components of healthcare spending in our system. The idea about impact on well-being of patients is particularly that mis- and overprescription of pharmaceuticals in particular, but also misuse of medical devices has significant healthcare problems, has significant healthcare implications for patients, which then also obviously can have expenditure implications for the healthcare system. Just to give you some ideas about how significant the problem is, in the US, for example, deaths as a result of the side effects of medication are now considered to exceed the number of traffic deaths. Another example, a study published in JAMA suggested in 2010 that annually up to 700,000 people may be admitted to emergency as a result of problems with medication. There are many other studies that confirm the very high rate of emergency admissions for adverse drug reactions and so on. Not all of that can be associated, obviously, with just the financial relations between industry and healthcare providers. But there is certainly a suggestion, and as I said, a historical record, that a lot of payments are targeting particularly healthcare providers with a potential impact on prescription practices. I can't discuss again that in much detail here, but if you look at the literature, so here I just put some kind of powerful titles of books that have been published but written by former editors of the New England Journal of Medicine, people who were involved in the Cochrane collaboration, so credible people who have documented the evidence, which is actually in more detail also discussed in the medical literature in a variety of studies. They basically show that the relations, financial relations between industry and healthcare providers, payments in particularly to physicians, impact on the production, the analysis, the publication, and basically the public and scientific presentation and the use of scientific knowledge. In other words, it impacts on whether drugs, whether we know what we know about whether drugs work and medical devices and so on work, whether they're safe, and when and whether they should be prescribed. So this is obviously associated with the significant advertisement marketing budget that pharmaceutical companies have and other industries have. Just to give you a sense of how significant it can be, the Bloomberg School of Public Health looked at the 2010 budget for marketing to physicians and came to the conclusion, it's always hard actually to obtain exact data about that, but came to the conclusion that in the US in 2010, $27.7 billion was spent on relations with physicians, marketing to physicians, so as a general term. So the expenses of marketing to physicians amounted to $27.7 billion. The percentage of other ideas you get actually from looking at the marketing budgets of particular companies to realize the importance of the impact. The percentage of revenue that is spent on sales marketing among pharmaceutical companies, for example, varies between 20 and 30%, which is extremely high compared to other industries. So some of the industries that spend the highest on marketing outside of the pharmaceutical industry, for example, spend only up to 8%. So there is a lot of spending taking place, again, as I mentioned, with potential impact on the conduct of research, on the promotion of scientific publications, the presentation of scientific publications, which has been associated with off-label prescription, which is often unsupported by scientific evidence, educational lectures that may overrepresent the benefits of patented products, manipulation of scientific literature, and so on. So has nothing been done? Things have been done. The data that has been obtained through studies has been used by governmental agencies, for example, to prosecute pharmaceutical companies with penalties actually dating up to 7.8 billion was one of the latest penalties. But these penalties don't seem to be sufficient. So they are seen as one of the tools that we can use to target these types of practices. But transparency is seen as a tool also not only to allow governmental agencies to know what's happening, but also to empower healthcare providers, the scientific community, patients, eventually the media and civil society in general to critically analyze what kind of relations do we have in the context of industry and healthcare. Are things done, or are things already, do we have already tools that relate to transparency? In the Ontario regulatory context, we do have already some tools. So there are already some transparency obligations, there are already some conflict of interest rules. We have the Regulated Health Professions Act and statutes and regulations relate to health professions, for example, the Medicine Act, under which we do have professional misconduct rules with respect to conflict of interest, with improper prescribing, with respect to potential misrepresentation and making unsupported claims. So some of these can be used. We do have also rules on advertising, on quality assurance, on record keeping, where you actually see that there is a particular emphasis on disclosure already in the context of conflict of interest. The problem is, how do we control whether these forms of regulations are actually sufficiently complied with? We do also have the Canadian Medical Association guidelines for physicians dealing with industry, again, which do promote transparency, which make an argument in favor of transparency, which provide some guidelines with respect to the funding of events, control of programs, and the content of programs, remuneration guidelines, and so on. But again, the question is, to what extent are these being respected? And to what extent are these sufficient? These are basically soft guidelines that do not necessarily lead to concrete enforcement. So that's where new regulatory approaches with respect to transparency become important. We have two types of approaches. We have self-regulatory approaches. For example, the European Federation of Pharmaceutical Industries and Associations introduced a disclosure code in 2013, which actually I just read today is being implemented more widely across Europe, and which will lead already to some form of semi-regulatory disclosure initiative by the Association of the British Pharmaceutical Industry, which will require full disclosure of payments to physicians in the UK, and will then be expanded actually to Europe in general. a recent poll actually suggested that 85% of the British physicians actually are happy with this or are pleased with the idea that they would have to disclose that types of relations. What I want to say something more about now briefly is some legislative and governmental regulations in the US and in France, because they do lead to a more stringent implementation of regulation. I'll go over these slides reasonably quickly, but they give you a sense of how firm regulations can be. So the US 2010 Federal Physicians Payment Sunshine Act covers physicians and hospitals and requires the disclosure to a governmental agency of payments and transfers of value of more than $10. So basically everything that people get in as physicians and in the hospital sector will have to be disclosed, actually, and are being put on a website of the Centers for Medicare and Medicaid Services, where people can access them and look for information about particular payment to physicians. There are significant penalties associated with it. Before the Federal Act, you actually have had in various states in the United States Sunshine Acts. Vermont is an interesting one because it has updated its legislation recently, looking at some of the shortcomings of its original, more softer regulation. So it has actually two particular sunshine-related acts. One is Prescribed Products Gift Ban and Disclosure Law, which prohibits gifts to physicians, so it actually goes further than just disclosure. It prohibits gifts to physicians and to healthcare providers. It requires reporting of expenditures to healthcare providers and institutions, including for samples and clinical trials. There's also Pharmaceutical Marketer Price Disclosure Law, which imposes reporting of comparative drug information by pharmaceutical companies, annual reporting obligations, and again, publicity on a website. I want to say something very briefly about the French Loi Bertrand 2011, because in my view it actually introduces a similar approach as in the United States, importance of disclosure, but to the wide variety of healthcare providers. Veterinarians, dentists, pharmacists, professional associations, students even who are involved in healthcare, patient associations, hospital, NGOs, consultancy firms, even those involved in the media and companies providing education, all have to disclose in France payments from industry. In other words, all those who in some way or another may influence the public, may influence healthcare providers, basically have to disclose their payments, the payments they receive from industry. Again, significant penalties associated to it. I'm coming to my last slides. What are some of the key issues that we can see in this area? I would say the key messages that you get from the analysis of some of the Sunshine Acts are cast the net wide. Make sure, as it happens, has been done in France, that all the healthcare providers, patient advocacy groups, all those involved are being caught in the net of the transparency provisions. Also keep the focus wide in the sense that various forms of payments and all forms of payments, even samples, the donation of samples should be captured by transparency rules. Industry has been very inventive in trying to construct new payment structures, so cast the net wide in that respect as well. Encompass various healthcare technologies, obviously, and also make sure that there are no exceptions. For example, in Vermont, they originally had an exception for so-called trade secrets. Well, most of the payments to physicians were immediately reformulated as trade secrets that should not be disclosed to the Vermont in the Vermont system. So they actually got rid of that particular exception. Finally, is it sufficient? No. It is one of the measures that we actually use to obtain basic information to then actually implement further measures. Can it be counterproductive? There's some suggestion that disclosure of payments can actually lead to a false reassurance within the system, to a false reassurance actually even by patients who may perceive payments to physicians as actually a sign that they are dealing with a very competent and knowledgeable physician, and that payments is actually something positive. So I would say in generally it's a first step. Education is needed, and further regulatory measures, including more strict conflict of interest rules based on transparency, are important. So thank you.
So all of our speakers have been very disciplined about sticking to their time, which gives us enough time for questions. I'm going to take the moderator's prerogative and ask a couple questions, but if folks would come to the microphone and get ready, I'll call on you in a second. So my first question actually for the panel is quite simply sort of what's next? There seems to be almost a cycle by which we decide something's important to look at. There's often something that's very profound. You could think about patient safety in this regard. We had a report that said that patient safety was in great jeopardy in Canada. Then we started reporting HSMR and other patient safety indicators. We went through a series of sort of sea changes where patient experience was obviously clearly a problem, and now we're talking about patient experience, not because it's related to something else, but because it's good in itself. And might say the same thing with conflict of interest. There's a body of evidence that's built up, some of it quite dramatic. A recent paper in JAMA showed that the degree of interconnectivity between the clinical professions and industry at the highest levels was very, very, very extensive. And now we're talking about transparency around conflict of interest. So what's next? What's the next thing we're going to look at?
I start?
Trudeau?
Okay. So I would say it, as I mentioned, transparency is a first step, but I wouldn't underestimate the importance of it. And actually transparency more from a regulatory level where you have strict rules and strict reporting obligations with potential penalties associated with it. Last year we actually had at our health law, in my health law course, a speaker come from the United States, Paul Tucker, who worked for the Senator Grassley Commission, the Finance Commission in the United States, who actually did an inquiry into the intrinsic relations between industry and healthcare providers. So they would systematically invite people to come and speak. They had the power to actually subpoena people to disclose documents to them. And so in the States, we already had, even before the strict sunshine legislation, voluntary reporting obligations, academic obligations in academic institutions to report payments from industry. So what the Senator Grassley Commission would do, they would invite, for example, first an academic investigator, clinician, who would come and speak and have to talk about her relations with industry and whether they impacted on her, for example, her publication record. And she would, for example, she would suggest that her payments were of a certain amount, say $100,000 in the last 5 years. After that, they would actually, the next day or a couple of days later, they would invite academic institutions where they would check what she reported within the academic institutions, and then they would invite pharmaceutical executives, and again, because of their subpoena power, they were able to access the records. Industry was always very reluctant, tried actually to frame things as a trade secrets, but because they could force them to disclose records, they would see that there was a significant discrepancy to what people report they get from industry and what industry really in practice pays to physicians and healthcare providers. So I would say it's important to have that information because there is a tendency to trivialize, to underplay the importance, the significance even of payments to healthcare providers, to academics who are involved in basically educating their colleagues and educating the public, and who are supposed to have academic credibility purely on the basis of their scientific expertise. So if we don't have firm access rules and firm rules that impose full transparency, we actually will never really understand the extent of the problem and be able to act upon it.
Okay, thanks. Virginia, you want to talk about what's next?
Sure. I'm going to take a fairly narrow view, I think, in terms of my answer, and really just focus in particular on the index. So rather than thinking of, different ways of reporting or different things that we might be doing in terms of communication, just thinking about the index in and of itself and where I see the focus over the next number of iterations. And this is really driven by both gaps that we currently see and also areas from a systemic perspective where we see people understanding and beginning to acknowledge that work needs to be done. So I would look at 3 areas, one being equity, and we've heard quite a lot about that today, including from Josh this morning. So really looking at how we can measure equity. It's not easy, and we know there are many, many dimensions of equity. So I do think that we'll be spending more time focusing on equity and how we can measure it, and then, of course, how it can be achieved in the delivery of the healthcare system and in outcomes. Second of all, I would look at efficiency, and again, this is driven by the fact that we have a limited healthcare budget, and we need to make sure that we are using our resources as efficiently and as effectively as possible. So I would think that efficiency is another area where we'll be increasingly focusing. And the third area, which is the one I really wanted to talk about in my last slide, which is end of life. And I think that around end of life care and palliative care, and again, ensuring that our patients are receiving the best possible care in the right place is critically important. And so how we can measure it, and therefore how that can be used across the system to improve performance. So that's where I think I see the focus of the index and the council on those three areas.
Great. Kathleen or Daphne?
Yeah, in terms of the kind of content topics, I think the connectedness of care across all of the sectors is a key piece of it. I think value for money, I think a lot of people talk about it, and we haven't really got our head around how to measure it. And sometimes we can get at value, and sometimes we can get at the money, but putting the two together is quite difficult. I think so those are the content pieces. I think in terms of the approach piece, there's a few things. We talked about, and I think Virginia talked about it, the indicator kind of life cycle. Once it's hit its objective, it has to go somewhere. But there's always someone who needs that number, and where does it go? And is there like a big indicator graveyard somewhere? Like what's the answer there? Is one piece of it. And I think the other thing, which I have to say, I have a bias. I'm very attracted to the infographic, the short summary. Presentation of information, but there's, I think a real risk of oversimplification of some of the issues in a very complex system. And how do we get the balance right between the kind of getting it quickly and having enough depth and exploration to really understand the issue?
Okay. Quickly, I don't know how many of you have heard of the term spontaneous demand. I read it for the first time in a report I literally read this morning from the UK, where they did this work on how's the public using public reporting and transparency tools. And really their conclusion is spontaneous demand does not exist. It's very rare. We don't wake up in the morning and say, I'm going to go look at this website and find out what's going on about X, Y, and Z. So I think what we really need to focus on is truly understanding when is it that you're going to go get up and look at that information. It has to match to, particularly for the public and the patient, it has to match to their journey. So I think what's next is that we are going to be further exploring what the public and the patient is really looking for, and it's going to be a struggle for all of us because the information and the data doesn't exist entirely today. I think that another item will be the private sector is going to step in and continue to fill the gaps. There's a huge demand for information that you can find on the internet, and I'm not sure that many of us in this room are meeting that demand for many good reasons. And so when that happens, the private sector steps in. So I think we'll be probably hearing a lot more about Yelp and RateMDs and those kind of sites in the future. And lastly, I agree around data visualization. If you do look at some of these leading websites, and NHS Choices is a great one, and this report that I read this morning actually talked about the fact that in the UK, the public is really recognizing NHS Choices. It's a brand. It's a national brand. It's where everybody goes to get their information. I think they get something like 9 million hits a month. And so what's happening there is that they're not showing information in any complicated way, and they are simplifying the information to the public. And I do think that, and I keep saying the public, but one thing we've also heard is actually most of us as professionals, very few of us, we're almost, we feel like we're different and maybe we can understand the data better. And when you do have research and surveys looking into that, it's actually not true. Many of us are as averse to the way we present data to our peers as we would be to the lay public. So some changes there will likely come too.
Great, thanks. I'll go to the floor now, and if you just introduce yourself before you ask your question.
Thanks very much. Enjoyed it. My name's Gord Wallace. For much of my career, I've been a medical educator involved in CME, CPD. And I think that's part of what we're talking about here, the undue influence of industry, particularly pharmaceutical industry, on those processes. So I can recall when, many years ago, I'm going to say 25 years ago, we were looking desperately for funds to fund. The universities were kind of withdrawing from this. And of course they said, get creative and innovative. And we did. We went to pharmaceutical companies and helped them and got their help in sponsoring conferences and the like. And of course that came at a price. So I think my comment basically is that we need to think of ways to better fund health professional education so that we don't rely on industry to the extent that we currently do. And there are also many attempts across the country to try to divorce scientific planning for conferences from the fundraising aspect of it. So I think there's some movement in this direction, but I think we do have to do more work on this and think about how do we fund all health professionals better in their education, of their ongoing education. I did have a question, though, for the panel. And so I've wrestled with this, again, in much of my time as a clinical physician. The indicators of my success have all been sort of around throughput, all right? How many patients did I see that particular time? How long did I keep my patients in hospital? All of those things. Those are good questions to ask because resources are an issue and throughput and efficiency is very important. But how do we marry that up with the right balance of quality indicators? Because I didn't have very many quality indicators at all, if any, over time. And how do we link those two together? And is there a way to kind of link what indicators related to what I'm calling throughput, access, to actually quality, so that when we think of those things, we think of them almost together, if you will. So that's my question.
Drew, you want to start off?
So it's more about health quality indicators, huh?
Yeah.
So transparent. The idea of transparency in general is so I will focus more on even with respect to financial information, but is there a lot of questions to be asked about what patients can do with information? In the context of the regulation of research, where I'm more familiar with, the argument is often made, for example, that full transparency of data is a dangerous thing because people will misinterpret research findings and will start interpreting on their own. The biggest response to that would be, we are actually dealing with a situation where we often have a misleading representation of data. So people can't be more misled by having access to full data rather than only having access to sometimes misleading data. So patients are never left on their own. So I'm actually happy to see that colleagues here on this panel are involved in the more translation of scientific data towards patients, in organizing websites which are more accessible, which are more understandable. So I think there is a lot to be done on the basis of transparency. Yes, transparency, just throwing data out there is not a panacea, but it certainly is a first step. And so you are indeed confronted with a time where the internet, when all kinds of people can make all kinds of statements on the basis of all kinds of data. So I think a lot of education is needed, a lot of empowerment of independent scientific groups that have credibility and were physicians and healthcare providers.